Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues in PGs, for the last couple of days, we are discussing management of chronic hepatitis B in the light of available guidelines. Today is the last episode of this discussion. And in today's discussion, we shall see how to monitor patients on hepatitis B treatment, how we will define our response, what are the definitions of response, and then we shall compare that how the present or the current possible response is different from the ideal response, and what the future therapies can help us in the treatment of the chronic hepatitis B patients. So when you start patients on treatment for hepatitis B, as we said that in most of the cases, this antiviral treatment is lifelong. Therefore, this patient needs proper monitoring. What's that monitoring? We shall discuss that in our discussion today. The treatment is the on-treatment monitoring and post-treatment monitoring. On-treatment monitoring, one is for the antiviral treatment efficacy. For this, we do the liver function tests, HBV DNA levels, HBe antigen and anti-HBe if applicable. If our patient is HBe antigen positive, then we will do E antigen and E antibody status as well. Otherwise, we will be doing the HBV DNA levels and liver function tests. And we do these investigations during first year every 3 to 4 months, and then second year onwards every 6 to 12 months. The HBs antigen every 12 months in patients with persistently undetectable HBV DNA. Initially, we check the liver function test, the ALT levels, the DNA levels, and E antigen status every 3 to 4 months during the first year, and then every 6 to 12 months. And when the patient's E antigen becomes negative, there's E antigen seroconversion if applicable, and the patient has got persistently undetectable HBV DNA levels, then we check HBs antigen every 12 months. And this is for those clearing HBs antigen should be tested for anti-HBs. And once the patients lose their HBs antigen, then we check their anti-HBs as well. This is the monitoring for the antiviral treatment efficacy. There is monitoring for the antiviral safety as well, because this is a lifelong treatment, so the safety concerns are there. Periodic renal monitoring in those treated with TTF and those at the risk of renal disease treated with any nucleoside drugs. So the periodic renal monitoring is important. And we do this by serum creatinine every 3 months during first year, and then every 6 months from the second year onwards. And of course, we check for the liver disease status as well. Despite the patient being on treatment, we check its status by doing EPRI score, FIB score, and FibroScan for liver cirrhosis, and of course, ultrasound and alpha fetoprotein for the HCC surveillance. These are the three main parameters they are monitoring. Tests or groups for the antiviral treatment efficacy, for antiviral treatment safety, and for the liver disease status. How we define the response to antiviral treatment? The response, the on-treatment response, and then there is off-treatment response. And the on-treatment response, it's different from the pegylated interferon and any therapy. The pegylated interferon is simple. When the DNA level is less than 2000, we say the patient has responded to the pegylated interferon therapy. For any therapy, for the nucleoside analog therapy, whether this is the entecavir, TTF, or TAF, the response is defined if the DNA level is less than 10 international units, then we say the patient has responded. When there is a less than 1 log decrease in HBV DNA levels after 3 months therapy, we say this is a primary non-response. You started a patient on antiviral treatment, and after 3 months you check the PCR and there is less than 1 lag drop, then we say this is primary non-response. One is partial response. This was full response. Partial response is that the HBV DNA is decreased by more than 1 log, but still detectable after 12 months of therapy in compliant patient. Patient is compliant, patient has taken therapy for 12 months, but still the DNA decrease is positive, but the decrease is more than 1 log, but still it is positive. So you say there is partial response. And one is the breakthrough when there is confirmed HBV DNA increase of more than 1 log above on therapy, nadir. The patient's viral load was decreased, remained there, and then there's increase. You say this is a breakthrough case. This is the virological response. Then there is a virological off-treatment response. This is virological on-treatment response, and one is virological off-treatment response. Virological off-treatment response is sustained response when the DNA level is less than 2000 ml for more than 12 months after end of the therapy. You start the therapy and the PCR level remain less than 2000, then you say that the patient has got the virological sustained response of treatment. What is this serological response? It is the HBe antigen loss and development of anti-HBs, and one is the E antigen, one is the HBs antigen loss and development of anti-HBs. So serological response may be HBe antigen serological response and HBs antigen serological response. And one is biochemical response, the ALT normalization, which is confirmed by ALT determination at least every 3 months for at least 1 year post-treatment. Patient treatment has stopped and you check the ALT levels and these are normal. You say the patient has achieved biochemical response. And histological response is defined as decrease in the necroinflammatory activity without worsening in fibrosis compared with pre-treatment histological findings. This is the graphical representation of the response. Primary non-response is when there is less than 1 log drop after the patients being on treatment. Partial response is more than 1 log drop, and response is when the DNA level is less than 10 units. So this is the patient has responded, and this is when the patient is partial response. There's a drop, but more than 1 log drop, but still it is positive at the 12 months. This is the non-response that the patients there is no drop, and this is the breakthrough when there was the down and then it rose up. So this is the definition. This is the primary non-response. This is the breakthrough. Yellow is the breakthrough. This is the response, and this is the partial non-response. Inappropriate virological response during oral therapy, as I said, this is again the same thing. A partial response is defined as on-treatment decline in HBV DNA level of more than 1 log, but failure to achieve undetectable DNA levels after 12 months. Primary non-response when who fail to achieve more than 1 log, and virological breakthrough when there is more than 1 log increase. This is we have discussed. So you start the patient on treatment, and this is 3 months, 6 months, 9 months, 12 months, first year, and this is the later on. So the ALT levels are checked 3 months, 6 months, 9 months, 12 months. PCR 3 months, 6 months, 9 months, 12 months. E antigen and E antibody status, you check for the 3 months, 6 months, 9 months, and when there is a response is achieved, then you check the HBs antigen levels. So the response of the antiviral treatment is, of course, you check for the virological response, serological response, biochemical response, and histological response. The on treatment, this we discussed for pegylated interferon, that the DNA level is less than 2000 at 6 months of end of the treatment. This is called on treatment, and off treatment response is less than 2000 for at least 12 months after the end of the therapy. For the oral, undetectable PCR levels after 12 months, and less than 2000 at least 12 months after the end of the therapy will be off treatment response. Serological response, again, this is the E antigen loss, E antibody seroconversion, and of course the S antigen loss and S antigen seroconversion. By chemical response, we detected that it should be normal throughout, as the same is the histological response. Few words about the resistance to oral drugs. This is the LAME, this is the Edifovir, this is the Tilbibidine, Entecavir, TDF, and TAFE. This is the first generation, second generation, third generation, and this is the first year, second year, third year, and 8 years. You see, the limivudine is notorious for developing the resistance, and that's the reason it is no more used for hepatitis B. Same was Idefovir and Tilbibidine. The Entecavir has got the 6 years 1.2% resistance, and the TDF and TAFE has not been documented. This is we already discussed. This is when the cross-resistance data for the most frequent N-resistant HBV strains. These are the HBV variants, different variants, and this is the LAME, Tilbibidine, Entecavir, Edifovir, TDF, TAFE, and this is how they cross-react with one another. When the patient develops resistance, when it's a patient is lame, experienced patient, then you start the patient on TDF or TAFE. When it's a tilbibidine resistant patients, again the same TDF or TAFE, Entecavir, again TDF or TAFE, Edifovir. If lame naive, you can switch to Entecavir or TDF. If lame resistance, then TDF or TAFE. And DNA plateaus, again aid. TDF or TAFE resistance, if lame naive, switch to Entecavir. If lame resistance, you aid on the TAFE patients. Multi-drug resistance, switch to Entecavir plus TDF or TAFE combination. This is the way how you tackle these patients. This is the last slide, and I would like to have your attention on this. Cure with the antiviral treatment. This is the hepatitis B virus. In acute phase, the patient has got S antigen positive, E antigen positive, PCR positive, and cccDNA positive. When the patient becomes chronic, again remains the same, that the patient HBs antigen is positive, E antigen is positive, DNA is positive, and the cccDNA is positive for more than 6 months, and it has got 2 phases then, E antigen positive phase and E antigen negative phase. With the current therapies, we can get the partial cure, and partial cure means that the patient HBs antigen, it remains positive, E antigen may be achieved, E antigen seroconversion may be achieved or is achieved, the DNA PCR becomes negative, but cccDNA is positive. Partial cure means when there is HBe antigen seroconversion and DNA PCR becomes negative. The functional cure will be when, in addition to the negative PCR and E antigen seroconversion, there's also HBs antigen seroconversion. This is what we can get with the current therapy, especially with the pegylated interferon. This is the maximum which current therapies, pegylated interferon, Entecavir, tenofovir, in the form of TDF or TAFE can give us the functional cure when there is S antigen seroconversion, E antigen seroconversion, and DNA loss. But if there is only E antigen seroconversion and DNA loss, this will be called partial cure. The current therapies are upcoming, as compared to the current therapies, the upcoming therapies, hopefully they will clear the cccDNA as well, and then this will be called a complete cure. So what we can get today with the current therapies is either partial cure in terms of the negative PCR and E antigen seroconversion, or functional cure in terms of the negative PCR, E antigen, and S antigen seroconversion. The complete cure where the cccDNA also becomes negative will be available with the, will be possible with the upcoming therapies. So, dear colleagues, current HBV therapy is not indicated in every patient, and once start, probably you will never stop. As compared to this, the upcoming HBV therapies, It will be for every patient and it will be of defined duration. So with this salient features of the guidelines, keeping in mind, when you will again go to those case histories, the first case history was acute hepatitis B, second case history was HBe antigen positive chronic hepatitis B, the third history was HBe antigen negative chronic hepatitis B, the fourth history was hepatitis B related liver cirrhosis and post liver transplant scenario. The fifth case history was acute the hepatitis B, chronic hepatitis B in the pregnant ladies. And the last case history was hepatitis B and E co-infection. When you go to those case histories, when you go through those case history scenarios, it will be now more easy for you to select the correct answers and to manage these patients. I hope this workshop will help you in proper treating your patients. And the most common pitfall which I have found is that the patients are treating hepatitis B patients are being treated on the protocols of hepatitis C. If we can understand that the treatment of hepatitis B is just like hypertension and diabetes in most of the cases, I think we are to the mark. And with the current therapies, we can either do the maximum, we can get the negative PCR and E antigen and S antigen seroconversion that is called the functional cure. Otherwise, we can get only the partial cure, which is the negative PCR and E antigen seroconversion. The cccDNA is still there within the hepatocytes, nucleus of the hepatocytes, and that's the reason the current treatment is a lifelong treatment, just like diabetes and hypertension. I hope the upcoming therapies, they will be clearing the cccDNA as well and will be giving us a complete cure. So I stop here. I hope you enjoyed being with me in these discussions. Inshallah, in the near future, we will be starting another interactive series on the other topics of the hepatology and gastroenterology.